Good morning. I'm always impressed when I see Liverpool graduates turning up to my lectures after they've qualified. It always makes me smile that you pay to listen to me speak. So, background is general practice and private practice, and then practice limited to perio. So I do come from a coalface dentistry. I'm not a pure academic. I do have the dubious honour of trying to convert those spotty teenagers that come in the first year at Liverpool into some of the best graduates in the UK. And I also teach with a company called Perio Courses. We run Section 63 courses all over the country, and I'd encourage you to go along and further your perio postgrad education. Because believe it or not, you listened to Perio Careers Talks yesterday. Perio is going to be a boom industry. There's no doubt about it. Whatever mantra was delivered, perio is going to be a huge part of future practice. As caries levels drop, perio rates are still going up. There's going to be a huge demand for perio treatment. So what I've been asked to look at is sort of an overview of perio diagnosis. We're going to look at medical legal aspects of perio and keeping yourself safe. And we're going to look at communication issues because we want to try and avoid dropping ourselves and our colleagues in it. So I'm going to try with this talk to avoid teaching how to suck eggs. You're all young, fresh-faced, or after last night, not all of you fresh-faced, but you're all young anyway, hopefully up to speed with perio treatment. So I'm going to try and avoid teaching you to suck eggs, but there are certain things in here that we've got to cover when we have a perio lecture. So if we start by thinking, well, let's identify that typical perio patient, because if we can identify the typical patient, we're not going to miss things, are we? So the typical perio patient, if we can list the characteristics, well, it doesn't really exist, does it? Because I did a bit of a sort of an audit of my last 10 referrals just to get an idea of the type of work I was seeing. We had, in the last 10 referrals, I had 5 men, 5 women. I had an age range from 18 up to 72. We had different ethnic groups. We also had completely different social demographics, from a consultant oncology surgeon. We had a guy who sweeps the streets. We had a retired teacher. Just across the board, my perio demographic is quite varied. So there is no typical perio patient. And as such, one of the things we're going to talk about today is not making assumptions with perio. And this hopefully will be a little bit of a theme. Don't assume you've got to be screening and diagnosing. You're clinicians, you've got to be making the diagnosis. Because if you make assumptions that, oh, this doesn't look like a perio case, then you're going to get into the hot water. Because assumptions lead to mistakes. So this guy's made the assumption that he can get his bike around the quayside, and that assumption was wrong. Assumptions lead to problems. Screen and diagnose, it's really important. So when you think about screening, you're probably all thinking, well, he's going to have a BPE slide here. Wrong. Screening and diagnosis starts well before the clinical examination. And you can start to listen to your patients because the patients are going to give you clues. So it's not uncommon for patients to say, well, my gums bleed when they brush. There's blood on my pillow in the morning when I wake up. How alarming is that? But that's something I hear all the time. My teeth feel loose, never a good sign. And patients telling you they've developed spaces. Look, doc, this gap that I can get a pound coin through, that was never there on my wedding day. Look at the pictures. It starts to give you an idea that you've got a perio patient. And it's really important that you document this in the notes. The whole patient-dentist communication thing is a really important part of our consent process. And so start to document the conversations that you're having with patients. We had this conversation at the university on Thursday. I was on the clinic with the undergraduates, and we had a patient who was on their 4th visit of perio treatment, and there wasn't anything in the notes that said they'd had the conversation about how perio disease works, why it works, what the patient's role was. All of these things were missing. It was just very practical, quadrant scaling and root planing, 47 visits later in the hospital. So get this stuff in the notes. This is important. Once you've listened to the patient, then you need to start having a look. You haven't got to touch them yet, just have a look. Because just by looking at the patient, you're going to start to get loads of clues. You're going to see inflammation, you're going to see red swollen gingiva. Sometimes you smell the perio patients as they walk in the practice, don't you? Because they have that sort of odour occasionally, that perio odour. But you can see recession, you can see missing teeth. There might be drifted teeth, and you might even, in extreme cases, as they walk in and start talking to you, you might see the teeth wobbling. And it doesn't take a clinical examination with 6-point pocket charts and radiographs to know that this patient has periodontal disease. So start to look. My 6-year-old, I was sat on my knee, had my 6-year-old sat next to me, and we were putting this presentation together, checking it for spelling mistakes. If you find any, please let me know. She wasn't checking my spelling mistakes. And she said to me, Dad, his gums don't look very good. And she's 6 years old. It doesn't take a clinician to know that's not right. But then we've got to start looking, haven't we? But the screening process allows you to start to think about a risk profile for your patient, even before you've looked in their mouths. Hopefully you'll all have printed medical history sheets, pre-completed before the patient gets in the chair, and there'll be clues on there, won't there? You know, you've got the well-documented risk factors, you've got smoking. The statistics we tell our patients, you know, they're 3 to 7 times more likely to have 4 to 7 times more likely to have periodontal disease. They're more difficult to treat, and all those other things that we have to get across. Diabetes, we know that you've got unstable diabetes as a significant risk factor for periodontal destruction. And I'd encourage you to look out for those patients who maybe are pre-diabetic, those undiagnosed diabetics. The British Council for Diabetes have told us that approximately 5% of the population are diabetic, and approximately 5% of the population are undiagnosed type 2 diabetics. And so potentially, if you're not seeing your patient respond to the treatment in the way you would expect, in the presence of compliance, potentially you've got patients who are a bit overweight, middle-aged, maybe be thinking about type 2 diabetes. You can do an awful lot more good than just saving a few teeth if you're going to pick up on things like undiagnosed diabetes. But it's giving you clues, isn't it, about a risk profile for this patient. Even looking at medications, medications can give you an idea about stress levels. So patients who might be on antidepressants or anti-anxiety medications, we know that stress has a role in periodontal disease activity, although it's very difficult to measure and control. And we know we've got medications that can affect the periodontium, whilst they're not risk factors for disease. You know, we've got our calcium channel blockers, our things like your nifedipine, your amlodipines, and all these anti-rejection drugs and anti-epileptics that might make oral hygiene difficult, which might be a secondary risk factor for future periodontal breakdown. So here we see a patient, and this is Adam. Adam's 16, a fairly poorly controlled epileptic. He's on phenytoin. And this poor guy's got his prom coming up. He's going to sit his GCSEs this year. These patients always seem to have a smile line that goes up to there, so they show everything. And you know, Adam, we can't change his medication because his epilepsy is so bad. So Adam is a surgical case that we'll mention later on. But we're building a risk profile. Here's the BPE slide. I told you it'd be here. You expected it to come, didn't you? It's still the medical legal standard for screening. It's got to be in done on every single patient at every single exam. For those of you who maybe have been on the moon for a while, those of you who don't know, this was revised in last year by the BSP. It's not been changed dramatically, but you have to know this document. It's downloadable through the BSP website. It's in the Young Practitioner's Guide that's in your handouts. You have to know this. You have to do it on every patient, and you have to write it in your notes. And if it's not there, it just makes life easy, doesn't it, for those guys who are against us. It's start of the diagnostic process. I will have hammered home to the Liverpool graduates that it's not diagnostic on its own, and it absolutely isn't. But this is the start of the diagnostic process. But it is only a screening tool. And you've got to react to the BPE, as you know, with the appropriate special tests, further investigations, and appropriate treatment. But know this document inside out. It's only 2 pages. There's even graphs and tables on there, so there's not a lot of reading. But this is the thing that potentially you're going to be tested against. So, we've done our screening. We're into the diagnostic process. Our screening is going to give us the patients who are possibly at higher risk. It might give us signs of inflammation, but it doesn't truly tell us about disease. We might know about increased pocket depths. All of these things are building a picture. But the follow-up ultimately is the clinical examination, obviously radiographs, special tests, pocket charts, and vitality tests. And all of these things have got to be in the records. While we're on the subject of radiographs, we'll come on to that now, you build this picture and you make your diagnosis. But on the subject of radiographs, I think it's really important that when you take your radiographs, that you can actually see the bone. We're all very good at taking our 2-yearly, or whatever the risk profile for the patients, our 2-yearly bite wings. But I'm forever seeing cases like this where we request the x-rays from the practice and we get year after year of x-rays where there's teeth with no bone around them, and they've no idea where that bone is. And I'd encourage you to look at your patients and pick your radiographs quite carefully based on what you're seeing and part of your screening and examination, because it would be really nice to know where our bone levels are around some of these teeth. And if you can't see it, maybe you should be thinking about some different views, because periapicals in perio diagnosis and perio treatment planning are still the gold standard. OPGs are great. I know digital OPGs now, the quality of them is fantastic. And I know that the radiographic dose is slightly lower with an OPG, but the diagnostic yield from periapicals is far superior. And so I'd encourage you with a perio case to be sticking with your periapical series. So we've worked our way through and we've made our diagnosis. The diagnosis then has to be written in the records, and believe it or not, dentists are really bad at this. Dentists seem to be very good at writing in their records caries, irreversible pulpitis, periapical periodontitis, and then they seem to write things like red gums or bleeding gums. Let's get into the habit of making a clinical diagnosis and having it in the notes, because it's going to give the Defence Society something to work with. And once it's in the notes, don't keep it a secret. Tell the patient. It's amazing how patients seem to be going for visit after visit after visit, blissfully unaware that they've got this condition, periodontitis. So use those words and explain what they are. If you're unsure, if you're not sure what you're seeing, then you can make a differential diagnosis. That's absolutely fine. And then you can do some investigations, you might be able to provide some treatment, and you can constantly revise your diagnosis. If you're really confused about it, maybe that's a time to consider referral, and we're going to look at referrals as the lecture goes on. It's important, the diagnosis in the notes. You know, we hammer this home at undergraduate level. The diagnosis guides the treatment plan. If you've got caries in the upper right 6, you're going to do some sort of restoration. If you've got periodontitis written in the notes, you're going to do some sort of periodontal treatment. Your diagnosis guides the treatment. Incorrect diagnosis, and we're going to look at this, might lead to inappropriate treatment, and inappropriate treatment may lead to potential issues. And the probably really important bit on this slide, you know, you've all gone into practice potentially where you've got hygienists and therapists, and I know how practice works. In most practices, the hygienists and the therapists are running the perio, and they're very good at it. I'm a huge supporter of teamwork in perio practice. But you at the moment are the only people who can provide a diagnosis. You are the only people who, when you reevaluate that case, can make treatment decisions on that patient. You are the only diagnostic person within the dental tree at the moment. If direct access comes in, that may change. But don't leave this to your hygienist to be making all the big decisions. Screen it, diagnose it, treat it, review your diagnosis. So, sticking on that point of diagnosis, you know, it would be very easy for me to talk about quadrant scaling and root plane and all those other bits. We're not going to do that today. We're going to look at things that potentially could trip us up. So diagnostic curveballs, things that present as perio issues, pocketing, but maybe aren't perio issues. So vertical root fracture, very common, often presents as a periodontal pocket, but they're usually slightly different to normal perio pockets in that they're usually very narrow, often just the width of the crack, literally the periodontal probe just fits into these spaces. The fracture may be visible. You may be able to detect it with a sharp probe, high magnification. But the one thing I'd encourage you to do with these solitary pockets is to have a look around the rest of the mouth. So if you look around the rest of the mouth and there's no perio disease anywhere else, and you've got a very thin, narrow, deep pocket, you've probably got a root fracture, probably not a perio case. And the endodontic colleagues tell me that they describe this J-shaped lesion. What do we mean by that? Well, this was a case that was sent to me for periodontal regeneration. The Liverpool graduates will tell you how excited I get about periodontal regeneration. It really floats my boat. But we looked at this, and this patient didn't have any perio breakdown anywhere else in the mouth. Heavily restored tooth, and under high magnification, we were convinced we could see a fracture. We could have done root resection maybe, but we took this tooth out. And lo and behold, you know, we were right, there was a significant fracture. And the important note here is that if we'd have treated this as a perio defect, no amount of treatment would have made this better. So the key is in the diagnosis. Root planing would have made no difference at all. More diagnostic curveballs, perio-endo lesions, endo-perio lesions, really quite difficult to treat and to manage. But they commonly present as some sort of periodontal pocket, exudate coming through the perio sulcus. Have to be thinking about checking vitality. If you've got deep pockets that extend towards the apex, you've got to be thinking about vitality. And if the tooth is non-vital, then you know how to treat periodontal lesions. Endo first and wait. You don't dive in too soon to manage the perio, because all too often the endo treatment will manage the perio problem. If it doesn't get any better following endo treatment, then you can go in and do your fancy, clever perio bits. So here's a case that was sent to me, an upper 6 with a class 2 fication, buccal fication, and I was asked if I could do some sort of perio surgery because they'd root planed this and it hadn't got any better. And it had a relatively shallow restoration, and so not unreasonable to think that it wouldn't be endodontic. But we tested this tooth and it was non-vital. So I passed this over to a colleague who did, I think that's a nice endo. I don't really know a lot about endo, but it looks quite nice to me, lots of nice white lines. But they did their endodontic treatment and we waited 3 to 6 months. And this just got better and better and better and better to the point where this fully resolved and the bone repaired and the pocket closed. And like I say, if we'd have treated this in any other way, if we'd have rushed to do our RSD, then potentially we'd damage viable periodontal ligament cells that could just repair once the endodontic infection has gone. Diagnosis is the key. So make the diagnosis. False pocketing, really common. It can be caused by inflammation. We know this. This is sucking egg stuff, hopefully. So gingivitis. Go to your radiographs. Those BPE code 3s, they're borderline cases. They may or may not be periodontal disease. Go to your radiographs. If the bone level isn't where it should be, it's potentially a periodontitis. If the bone level's in a normal position, it's a gingivitis, and treat it as such. So this case was sent to me. This was actually sent to me as that they thought it was a biologic width invasion, and they wanted me to do crown lengthening surgery, but it makes the point. This was sent to me because of this persistent gingival inflammation, and the patient just wasn't cleaning properly. They got new crowns, didn't want to damage them, so they better leave them alone. And 4 weeks of simple oral hygiene instruction almost resolved this case, a little bit left on that central. And we know from studies, if we dive in and treat this as periodontitis and we start treating these inflamed shallow pockets, we know from Lindy's work that we're going to get iatrogenic loss of attachment. Again, diagnosis is the key. False pocketing can be a bit weird and wonderful. So we mentioned Adam before with his drug-induced gingival overgrowth. We also see, and very rarely, thankfully, things like gingival fibromatosis. So there's Adam, as you remember from before, with his phenytoin drug-induced gingival overgrowth. And this is Megan. Megan's 16. She has hereditary gingival fibromatosis. Diagnosis is everything. With both of these cases, we exhaustively try non-surgical therapy. With Adam, we write to his neuro department and we see if they can alter his medication. And that's something we do on a regular basis, certainly with people who are on things like calcium channel blockers for hypertension, because often just a simple change in medication can be the thing that will have this resolve. And we're trying to avoid surgical treatment where we can. So often we'll liaise with GPs, we'll alter medications, providing we can get away with it. Often the epileptics and often the anti-rejection drugs, they don't really want them messed with. And things like gingival fibromatosis, they're almost certainly going to be a surgical case. I mean, I treated Megan recently. We got through 43 blades, just treating 4 to 4 over 2.5 hours. It's like cutting shoe leather, this stuff. It's the only case I've ever done. I hope it's the only case I ever have to do because it's the most unpleasant surgery to do. And these are cases that are going to be outside of your comfort zone, potentially, and they're the cases to be thinking about referring on. Sticking with diagnostic curveballs, hopefully you wouldn't get this one wrong, but gingival recession. People think gums have shrunk, must be gum disease. Well, we know that's not true, because we know recession can occur without periodontal disease, because we often see this in thin gingival biotypes. And I think potentially this is going to be a medical legal problem of the future, because I'm seeing more and more patients who are having non-extraction based orthodontics. So there's lots of these GDP systems out there which I have absolutely no problem with. 6-month smiles, CFast, Invisalign, other systems are available. But non-extraction orthodontics, teeth are pushed out of the radius, they expand the arch to create space. And if you're thinking about labial tooth movement in thin gingival biotypes, don't be too surprised if things like that happen. I've had 6 cases referred to me in the last 3 months where this has happened mid-orthodontic treatment, and I think this is potentially a medico-legal problem of the future, because you have patients who are turning up for aesthetic treatment, orthodontics, who then end up like that. They're not happy. So far, the 6 I've had in the last 3 months, the dentist is paying my bill to fix this, to keep the patient happy. There's a message there as well, I suppose. But if they think about the tooth movement first and assess the biotype, they might think about an alternative treatment strategy, extraction-based orthodontics. Because when you look at this case from the incisal view, you can see that they've just pushed this too far. Teeth want to move within the bony envelope, but that bony envelope wants to be where it wants to be. And if you put a tooth somewhere else, then you're going to stress the tissues over this area, and any little bit of trauma, it can be toothbrushing, it can be eating, and these things are going to go, and they go fast. They go really quick. Now, we could move that tooth back, and that might help things get better, but the patient quite likes the appearance. So we're probably going to do some sort of grafting. You'll see on there we mentioned traumatic overbite. So your class 2 patients, these patients who have, how sore does that look? Really uncomfortable. So they cause this gingival stripping by this traumatic occlusion. And again, I keep saying this diagnosis is the key. We really have to assess this very carefully, because the first case, we've got a Miller class 1, borderline Miller class 2 recession defect. I know that with some simple grafting from the palate, I can make that look better. With the second case, if I graft some tissue into here, they're going to go home and bite it off. This patient's going to need some sort of orthodontic restorative management prior to correcting that gingival recession, if we feel the need to correct it. And if you overtreat these sites through periodontal therapy, RSI, then potentially they're just going to get worse because they've got shallow pockets. Lindy's work, critical probe in depth, managing shallow pockets, you don't need to be doing lots of root surface instrumentation. Diagnosis is the key to these cases. Periodontal disease on its own can throw up a few diagnostic curveballs, and this is a bit of a bugbear of mine. We've got classic periodontal disease, we all know what that looks like, but is it chronic? Is it aggressive? Is it active? Does it matter? Well, it absolutely does matter. It matters to this girl. She's 26. Yeah, 26, been going to the dentist every 6 months, and we've got the notes because this has become medico-legal. And she's been passed on to me to now manage her care. Every 6 months, having some sort of periodontal treatment, never ever offered a referral. The blanket diagnosis of periodontitis, and it goes without saying that this is aggressive periodontitis, which warrants a specialist referral. So this absolutely does matter. So while we're on this point, let's have a quick review of aggressive and chronic perio, because I'm constantly getting patients sent to me. I mean, she's been sent very late, but patients in the mid-30s, heading towards the 40s, and the practices have been putting them through round after non-surgical therapy. They've been squeezing things into pockets. Nothing ever gets better. We've got x-rays that show the bone just disappearing, and it's been a lack of diagnosis of aggressive disease, and they respond incredibly well to some simple management. But I would encourage you to get these patients out of your practice and refer them on. So, aggressive disease, let's just have a quick recap. Hopefully this is sucking egg stuff. Has a strong family link, much, much stronger than chronic disease. So if you suspect aggressive disease, start asking about family patterns of disease, because it almost never skips a generation, but occasionally it does. It's usually young patients, but age has gone out of the equation. So you remember the 1999 classification. Age has nothing to do with anything. I had a 54-year-old patient. We have got x-rays that show in the last 18 months she's lost 4 mils of bone support around all of her teeth. That's aggressive disease in a 54-year-old patient. Young people get old disease, old people get young disease. But it is usually young patients like the lady we saw a minute ago, that 26-year-old. I've got 3 patients at the moment we're managing at the hospital under the age of 18 with really advanced 70% bone loss around centrals, laterals and molars. Devastating condition. You get very rapid breakdown at multiple sites. I need to see your x-rays. When you refer on for perio, don't just send me the last x-ray you've taken. Send me a series of x-rays because I want to know the speed of progression of the disease. It's going to help me with my diagnosis. And these patients are clean, so they tend to have low risk factors, smoking, the other bits, and they tend to be spotless. And then on a radiograph, we tend to see lots of vertical bone defects. Not always, but commonly see vertical bone defects. So here we've got a 24-year-old patient. This is at presentation, so no oral hygiene instruction has been done. That patient looks pretty clean. That could be a patient who's had a bit of ortho. We mentioned teeth have been pushed out. That could be the cause of that recession. The only real clue on this picture is the loss of interdental papilla in between the centrals, because we've lost tissue, so that means we've almost certainly lost some bone. Soft tissue follows hard tissue is the thing I'm telling the patients all of the time. But this is the type of case that if you're not screening, you're going to miss. Because when we look underneath the gums and see what's going on, 24 years old, relatively little visible inflammation, great oral hygiene. The only thing I'll add in now is this patient was Chinese. We know that in certain racial groups, there is an increased epidemiology and etiology of aggressive disease. So as high as 5% of the population in Afro-Caribbean and Asian populations have aggressive periodontitis. In the Caucasian population, it's almost sort of 0.1%. The last 8 aggressive perio cases I've seen were all Caucasian patients. So don't be caught out, screen and diagnose. Chronic's the one that we see day in, day out, isn't it? You're probably going to see it, if you're seeing 20 patients a day, you're going to see it 4 or 5 times in that day. So the genetic basis is less clear, but there's no doubt there's family patterns, and I'd encourage you to talk to the patients about their knowledge of the family history of their disease. The nice thing for you guys in general practice is that when you start talking about family relationships, you can be if you get an aggressive periodontitis case, then you need to be thinking about screening their children and having them in really good preventative programs, because they're going to be high risk based on what we said in the last slide. And it's quite holistic. Mums and dads love it when you're treating them but protecting their children. It's a real practice builder. So with chronic, we usually get those fairly cruddy mouths, similar to the slide we showed earlier on, the one that my 6-year-old daughter diagnosed. So they tend to have high plaque levels, they tend to have lots of calculus, they maybe smoke, significant risk factors. Slower breakdown of support, tend to be older patients. It's almost a lifestyle disease, and it's completely treatable and often preventable. So they're the things not to miss. We know that we're working to this classification. This slide isn't overly important, but don't get those bits wrong, because we've shown quite clearly that if you get that diagnosis wrong, the patient gets the wrong treatment or no treatment, and things aren't going to get better, and that's potentially going to cause problems. So I think, sat in the audience, general practice, what do we expect from you in terms of perio diagnosis? I think we'd expect you to be able to diagnose acute conditions. I never ever see AUG because I'm in secondary care. When I'm in my practice life, it's referral work. In the hospital, I'm seeing patients on referral. So I don't see these acute conditions. But depending on where you live, where you're practicing, you're going to see AUG quite a lot as a primary care practitioner. Perio abscesses, perio endo, all of these things should be well within your capabilities to manage. Gingivitis, you'd like to think that you'd have a good go at that, teach them to brush their teeth. And chronic periodontitis is well within your remit to treat. We'd also expect you to get that diagnosis right on aggressive disease. I'm not expecting you to treat it. We're going to talk about referrals in a second, but we're expecting you to get this right and not miss it. And I think the other thing we want you to be spotting is abnormalities of the gingivae. You're not there to make the big diagnosis though. Abnormalities of the gingivae potentially are referral cases. So I would expect you to know that that ulcer shouldn't be there. I'd expect you to review it. If it's not better after a couple of weeks, I'd expect you to refer that on. If you've got things like desquamative gingivitis, erosive lichen planus, by all means make the differential diagnosis. I'd encourage you to get a true opinion, max fax, oral medicine, whatever you have access to. Because even in our department at Liverpool University in the perio clinics, we're going to refer this downstairs to oral med. And oral med are going to offer biopsies for almost every lesion, because that's the one true way to make a diagnosis. Differential diagnosis from you guys, offer referral and document that you've offered that referral. Simples, isn't it? Dead easy. Brilliant. If it's that easy, why do dental protection and the GDC tell me that most perio litigation centres around failure to diagnose and failure to treat? We've just seen how easy this stuff is, and yet as a profession we seem to be doing really badly at it. And I'm told that perio litigation is just booming in the UK. And the case that we showed, the generalised aggressive case, where that patient was almost certainly going to lose that dentition, is the patient is looking at probably a 6-figure payout based on some of the information I've had from the dental protection people. 6 figures to the patient, and then significantly higher bill for professional legal services. These are expensive cases when they go wrong. So let's try and help our defence colleagues by giving them something to work with. Get these things in the notes, give them something to defend. So you're all sat there thinking, so what? Any of you welcome to come to our Saturday morning workshops in our house. We do plasticine, perio surgery. You have to bring your own pyjamas and your own plasticine, but you are welcome to come. So what are you going to treat in practice? You should be able to treat gingivitis. You should be able to treat the perio abscess, simple curettage, maybe a bit of irrigation, whatever you decide you're going to do. AUG, well within your capabilities. Chronic periodontitis, absolutely. The liver, I don't know what it's like where you're working around the country, but the Liverpool referral criteria is that we expect you to have done 2 rounds of non-surgical therapy, reviewed the outcomes, and the patients have at least 1 code 4. That's the hospital referral policy. Now that doesn't mean that you can't refer it somewhere else, but that's the current guidelines from our institution. There may still be patients who have significant disease after that treatment that you might want to think about referring elsewhere, so maybe privately. I think we'd expect you to treat simple perioendo lesions. I don't think that's unreasonable. But when we look at what you're going to refer, well, you might refer chronic periodontitis. If the patient's non-responsive, think about referring it on. You don't want to watch the patient slowly but surely deteriorate, but do have a go at it. On the diagnosis of aggressive, offer a referral. Don't start messing around with treatment. Just offer a referral straight away. The BSP, in your young practitioner's guide, you'll see there's they have a complexity guide on cases that should and shouldn't be tackled by GDPs and specialists. And it's only codes 1, 2, and 3. And the highest level of complexity is code 3, and aggressive periodontitis is very near the top, including patients who are medically compromised and other conditions. Refer those cases out. You might consider referring perioendo. They are particularly challenging. They can be a bit hit and miss. And so if you're not confident, think about referring that onto some sort of multidisciplinary team or a restorative consultant who's trained in the different specialties. And refer those abnormal periodontiums, as we mentioned before. And obviously mucogingival situations, you're not going to be taking those on. You're not going to be doing free gingival grafts. Think about referring these cases if they need treatment. And obviously, anyone needing surgical perio, you're going to refer that on because at your level of experience, you're not going to be managing that in practice. Ultimately, what you treat and what you refer boils down to competence and confidence. If you're competent to do it and you're confident to treat it, by all means have a go. The minute you feel uncomfortable and it's outside your comfort zone, think about referring it on. Don't assume, remember we said about assumptions, the guy who drove around the quayside and we said don't assume patients don't have disease. Don't assume that patients don't want to be referred, and don't assume that they can't afford a referral. Hopefully you'll have access to some sort of NHS referral pathway, but if you can't, private referral is absolutely fine. Don't make assumptions the patient can't afford it, because you're their dentist and not their bank manager. You're the person who's there to tell them what they need. They make decisions on whether they travel, whether they want it, whether they can afford to pay for it, and that's really important. I worked in a practice, a big implant practice up in Cheshire. We had a guy who'd won the lottery and he'd won £9 million, and I re-cemented his post-crown every other week and he wouldn't pay for an implant. In the same practice, we had a school caretaker who came in, he had a loose lower denture. He was quoted £5,000 for 2 implants and a new denture. We didn't see him for 4 years. He came back after 4 years and he had his £5,000 saved up. And he said, your prices haven't gone up, have they? And obviously they had, but we honoured that quote. People value different things and people make choices on what they spend the money on, and you don't make that choice for them. Tell them what they need, let them make a decision, and document it. So, we've looked at diagnosis, we've looked at the screening. Let's just have a quick look at how we can hopefully help ourselves with risk management. I'm sure all of your patients walk around like this. I'm sure my patients do, because I'm brilliant. But there are patients who are probably walking around like this. See the smiling assassin? Ha 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 ha, gonna get you. Let's look at how we can manage our own risk from a periodontal point of view. So I try and look at it in different ways. I think about my own personal level, things I can do to protect myself. Well, I can document everything that we've described. So I can document my assessment, my BPE is in my notes, my special tests, any of those things that I'm going to prescribe, I'm going to comment on in my records. I'm going to write a diagnosis. The least we want you to put in there is periodontitis. Don't put red swollen gums. That's what you say to the patients. Periodontitis is the diagnosis, and ideally chronic or aggressive. Don't think it's appropriate to be getting that wrong. Put it in the notes. We're bad at it. We then need in the records that you've explained what that diagnosis means to the patient. It's no good to say to the patient, you've got periodontitis, thanks for coming, see you next week. That's not appropriate. That isn't valid consent, it's not informed consent. Explain what that diagnosis means, and you need some way in your notes to convey the understanding that's taken place with that patient. Document what oral hygiene you give. Don't just write down OHI. I put down oral hygiene given, single tufted brush shown, green and yellow TPs, modified BAS technique. Very quick, very cut and paste if you have a computer-based system, but it's tailored to the patient. And OHI is a bit of a throwaway comment. Tailor your oral hygiene to the patients and have it in the notes. And ultimately, you want your treatment plan there, you want your treatment reviews there, and you want to comment on the clinical outcomes. So this is all starting to build a picture that will allow our colleagues at Dental Protection to help us in the event of a claim. On a personal level as well, we've got to show this understanding. How can we do that? Well, we can have the verbal communication, but then we try and back that up with written communication. Because the psychologists tell us that verbal information backed up with written information is much more powerful. I'm not convinced all of my patients read the stuff I give them, but hey, that's their problem. So I have a basic sheet that is on the computer that we print off that says, so you've been diagnosed with periodontitis, what does that mean? And it's a very, very simple document written in plain English, jargon-free, that the patient can understand. And I've also got it in my notes that I've had the conversation, and it's my way of trying to belt and brace the patient's understanding. Because when you back up written information with verbal information, it's very powerful. You can picture the verbal communication that went on in this household, and then she's quite eloquently backed that up with written communication that he will never forget. That's a true picture. Didsbury High Street. There's a lesson to learn, isn't there? Moving on from personal things you can do, we can look at the patient level risk management. So your patients need to be in absolutely no doubt that plaque is the primary cause of the disease, and they need to understand their role in removing that plaque for the disease to be fixed or to be stabilized. That's crucial, because the medical legal cases I've been involved in, the patients tell fibs. Oh, well, he never told me that I had to stick that brush there, and he never told me that I had to give up smoking. Well, really? Anyway, document that you've given this information. You need the patients to know you can't cure this disease. I use the diabetes analogy all the time. Once a diabetic, always a diabetic. Once a perio patient, always a perio patient. We can't cure it, but we can control it. But we need a teamwork approach to get this thing to work, and the patients need to know that. Tell patients that gums are going to recede. Perio, it's one of the one area. I work in a practice where we have sort of guys who do beautiful restorative dentistry. They make people look fabulous. We have a consultant orthodontist. She does fabulous work. I then rock up and make everyone's gums shrink, and it looks horrendous. But I know it's going to happen, so I tell them at the start, and it doesn't look like an excuse once it's happened. You know this is going to happen. You've got to explain the role of modifiable risk factors. Anything that they can control, they need to know about. Smoking, glycemic control, any of those things, they need to be aware of the role that they're playing. And I've heard it where patients have said, oh, if I'd have known that, I'd have stopped smoking. Now, whether they would or they wouldn't, we'll never know, but the patients use that against us. And I also talk about the genetic nature of the disease. Now, it's difficult to write all this on a little piece of paper, which is where those printed handouts come in. If you're in a practice where you have written record cards, it's quite appropriate to have printed sheets in the drawer that you then write into your record card, perio sheet 1 given. And if ever anyone asks, what's this perio sheet 1, you can just present it and it's there. And it's a way of getting lots of information into the records. But I'd encourage you to write decent notes as well. Compliance is a huge thing. We've got to get compliance issues into the records to be able to help defend ourselves against claims for periodontal neglect. And when you think about periodontal compliance, I'm sure you're all thinking about plaque and plaque control and oral hygiene instruction. And you're right, you know, inadequate cleaning is absolutely something that we want in the clinical records. Because obviously without that, none of our perio treatments are going to work. I don't care how you do it. I don't do a lot of plaque scores in my practice because I think the patients do special occasion cleaning. You know, we're going to go see the perio man, better brush my teeth for 14 minutes. And it's so they come in spotless, bleeding, because they've just been brushing in the toilet before they come in. So I don't do a lot of plaque scores. I do lots of marginal bleeding scores because it tells me what's been going on over the last 7 to 10 days. I take lots of photographs, and it's a record of their oral hygiene, and it allows me to document their lack of compliance. But lack of compliance is failure to respond to anything you've advised them to do. So failure to stop smoking is a lack of compliance. Yes, it's difficult, but you need to do this to help control your disease. You're not doing it. Get it in the notes, really helpful. People who don't turn up to appointments, if they're sporadic attenders, don't make their hygiene visits, that's a lack of compliance. You've advised them that's what they need. They're not doing it. Get it in the notes. It's a lack of compliance. As is failure to attend at the frequency you prescribe. All my patients go into 3 monthly maintenance programs. After a while, they sort of think, oh, I don't really need this. I'll just come every 6 months. And I say, well, no, actually, I really want you every 3 months. Well, I want to come every 6 months. Okay, in the notes, because they're not following my advice. And failure to accept a specialist referral is also a lack of compliance. Offer the referral when it's appropriate. If they don't want to go, that's fine. You haven't got to drive them there. Just put it in the notes that they've not accepted that referral. Because the documented lack of any compliance is going to help the dental protection people to defend you in perio litigation claims. Because if a patient refuses referral, you've got to then explain, there's this concept of informed refusal. When they refuse either treatment or a referral, you need to explain to them the consequences. So, right, Mrs. Jones, you're not having your perio treatment. For some reason, you've refused. Your teeth may get worse. The gums may recede. You may lose more bone. Teeth may fall out if you don't have this treatment, don't have the perio referral. Have that in the records and the understanding, because that's informed refusal, and that's really important. So the dental protection people tell me. Because we're trying to avoid confusion. So I'd encourage you, we're going to play a video. The Liverpool graduates will have seen this 100 times, but it's my favourite video. I want you to think about this scene as a dentist and a patient, a hygienist and a patient, or a periodontist and a patient. And we've got to teach patients how to use the tools that we're going to give them. So don't just give oral hygiene instruction and don't see the patient do it, because you're going to end up with this happening.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No.
Never answer that question.
Why don't you show me how your inhaler works?
Now just imagine that's a toothbrush. Patients haven't got a clue. You know, you see patients who've got these 200-pound Sonicare whatevers, and they look like they brushed their teeth at the other end. So, you know, your oral hygiene instruction has to be tailored, and we're trying to get through this consent process. One of the things we're doing quite a lot of, and it's a bit wacky and you feel a bit of a plonker when you do it, but we're starting to video patients' oral hygiene instruction on their mobile phones. We used to give them printed sheets of photographs of them brushing their teeth, and it was part of our written communication back to the patient. Nearly everybody has a smartphone with a video camera. We ask the patients if they've got it. This is the patient brushing their own teeth. My nurse is videoing it, and it's tailored to the patient. They've got a permanent record of where they shove that blue brush, where the yellow one goes, where the green one goes. Now, I can't put that in my notes, but I can put the fact that I've done it in my notes, and it's just a bit quirky. Some people hate it. Other patients who are a bit geeky and technophiles, they absolutely love it. It's just something to have a think about. Coming to the end, thinking about risk management, we can look after ourselves, we can look after our patients' side of things, but sometimes other people might drop us in it in other ways. So one of the most difficult situations is when either a new patient rocks up with what looks like undiagnosed and untreated perio disease, where still your VT trainer is off, and one of their patients comes in and we've got a difficult situation where they've got a perio abscess, they don't appear to know they've got periodontal disease, or you buy a practice and you inherit a load of supervised neglect. It's an absolute nightmare to deal with, but there are ways potentially that we can hopefully reduce the chances of litigation. So third assumption, don't make assumptions on what's gone before. You don't know what's happened previously to that appointment. And so I'd encourage you to stick to the facts. Say what you see, bone loss, recession, mobility, and based on that, make a diagnosis on the day and offer the appropriate treatment. Don't get drawn into he said, she said, they said, because it's a minefield. Because we want to try and avoid blaming or accusing colleagues, because you just don't know. And you want to avoid criticising colleagues' work. I remember as a young dentist, it was a while ago now, but I remember as a young dentist thinking I could fix everything and I was better than everybody else. You probably all feel a bit like that. And I remember a patient coming in who had what looked like a really horrendous amalgam placed by one of my colleagues. And the patient said, oh, it's a bit rough and I don't like it. And I said, oh, it's rubbish that. I can do loads better than that. And she said, oh, brilliant, that's great. Yeah, go for your life. So we sat her back, open wide, Mrs. Jones. 45 minutes later, the filling was worse than when I started. You just don't know what's happened until you start treating patients, so don't make assumptions. Because you only know their version of events. You don't know whether the patients are telling the truth. Now, I'm not saying patients are liars, but they sometimes don't tell the truth. And there are usually two sides to every story. Quick show of hands, how many people have had the situation where the patient says, oh, I had a difficult extraction, it was so bad, the dentist had his knee on my chest. Who's had that? Right, hands down. Who now has been in the middle of a difficult extraction and thought, I know what I need to do? It's an absolute old wives' tale anecdote. So, but it's out there, and more than half the room have heard that conversation. Not one of us has thought this is the way to go. So there's two sides to every story. Importantly, though, when we're delivering these messages, no one's asking you to lie. No one's asking you to cover up. You know, we've just had that report recently, the mid-staffs thing and everything. Oh, what a horrendous situation. No one's asking you to cover up for other people and things that are going wrong. Your duty is to the patient first and yourself second, and everything else hopefully will fit into place. But stick to the facts. Just say what you can see and don't be drawn in beyond that. Because if you've got professional concerns about colleagues, there are other ways to manage this without airing that in front of that patient. And so I'd encourage us to think about that really seriously. Because there could be some quite unhelpful comments made. So we're right near the end. So, you know, gosh, Mrs. Jones, not sure what that other fella's been doing, but you've got really bad gum disease, isn't going to help. That patient suddenly is thinking, oh, he's been doing something wrong. This guy thinks the other guy's not very good. Let's have a think. I might do something. You know, I'm not sure how they've missed this, Mrs. Jones. You must have had this disease for more than 10 years. That's not helpful. Neither is, let me just go and get a card for my friend at the dental law partnership. Sorry, I just need to wash my mouth out. I said dental law partnership. Always leaves a bad taste. These aren't helpful. So let's have a look at things very quickly that we can say, because I am in this situation all the time, probably once a day when I'm doing new patient clinics. So I'll often say to patients when they say, shouldn't this have been spotted? And I'll often say things like, it's really impossible for me to comment on how long this disease has been there. Periodontal disease and bone loss can be very fast, it can be very slow. All I can comment on is what I'm seeing in front of me. And if you want to discuss this further with the clinician who's known you for longer, then maybe you should go and have a chat with them. All I can talk to you about is what's here now. And then I'll also try and get them to focus on moving forward. So I'll say things like, look, I appreciate your concerns, but I really think we've got to look forward at where we're going to take this case and how we're going to manage your treatment together. And I'm sure with some combined effort, we can make this into a much, much better situation. And you're constantly trying to make the patients look forward and not look back wherever possible. And you get those patients, and I see it all the time, patients who've been in a practice, they've been having hygienist visits every 3 months, They might be in DEM plan and it's part of their care package every 3 months, and it's just not working. It's almost a supervised neglect. And they get very prickly because they've been paying into these schemes. And I'll often say to them, well, look, that hygienist treatment you've been having every 3 months, it's probably helped to slow the progression of the disease. So it's certainly not made things worse. If anything, it's probably slowed things down. But based on current thinking, you've still got signs of active disease. What they were doing before hasn't really worked. Let's try something different. And it starts to sow the seed that maybe it's not all bad. Maybe we just need to have a bit of a different approach. But you can see that these things are less inflammatory than the, God, Mrs. Jones, this looks terrible. What was he thinking of? Start to think about every word that comes out of your mouth, because patients hang on every word. You'll be pleased to know we're at the end. Summary: screen, screen, screen again, and then document everything. Be guided by the clues that are there. Document everything, including the understanding bit, and I appreciate that's very difficult, and document refusal of any treatments or referrals that you offer. Stay within your comfort zone, work within your competencies, and don't step beyond them. Refer for those treatments. Diagnose, don't assume, is the most important bit. Get the diagnosis right and the treatment will follow and it will work. And be ready for those difficult situations, because you will inevitably come up against them. And as my friend Roy Walker would say, just say what you can see. Stick to the facts, say what you can see. Thanks for listening.